So today topic of our lecture is Uroradiology Part 1. In this lecture we will be studying about the male and female urinary system and the male genital system. Now for the female genital system we will be having a separate lecture that will be called the imaging of the female pelvis, and in that we will discuss about the female urethra. But for this lecture, we will only study the male genital system and the male and female urinary system. Normally, the imaging of the urogenital system relies on ultrasonography. Why? Because it's fast, it's reliable, it's quick, and it doesn't give any ionizing radiation, but it also gives us very reduced resolution. And a lot of diseases and a lot of various conditions cannot be picked up on ultrasound. So for more detailed study of both the cortex and the medulla of the kidney, ureter and the urinary bladder, contrast enhanced CT scan is required. And for the male urethra, usually its opacification is done via contrast medium, and then the lumen of it is studied. Now whenever we do the imaging of the urogenital system, there is some problem that we want to rule out. So the first of the scenarios we might encounter is a trauma. Now if the trauma is blunt and the patient is only suffering from microscopic hematuria, then there is usually no need of any imaging. But if the patient is suffering from severe trauma or there is some penetrating trauma, then certain modalities are used. Now all of these modalities are not used concurrently. Some modalities are used in certain conditions and some are used in other conditions. Now which modality to use in which, we will be discussing one by one. The first one to study is the normal radiograph, the plain X-rays. Now for the urogenital systems, we do not perform plain X-rays. The usual X-rays are mostly contrast enhanced. Usually some kind of retrograde study is done. And even if it is not enhanced with a contrast, we perform what is called a KUB X-ray, that is your kidney, ureter, bladder. So only that part of your abdominal cavity is highlighted in the X-ray. The next modality that we used is the contrast enhanced CT scan of both abdomen and pelvis. Now contrast enhancement is necessary because urogenital system consists of a variety of various tubules and collecting ducts. Some of those are major, such as the urethra and the ureters, and there is a collection point, that is the urinary bladder. So in order to get a better view of all of them and get a better detail, we usually perform a contrast enhanced CT scan study. Next modality that we use is a FAST exam. Now FAST stands for focused assessment with sonography in trauma. Now during trauma, patient is always in emergency. So in order to perform any kind of imaging, usually all of the treatment, the stabilization of the patient has to be stopped and the imaging process has to be started. But fast exam, because it's both portable and fast, can be done on the bedside while the patient is being treated on. So not only it is fast, quick, reliable, and it gives us an internal view, especially in a blunt trauma. It is very, very vital. The next modality that we usually use is a portable abdominal radiograph. Now they may be of some value in certain conditions, especially if the trauma is blunt. In penetrating trauma, do not perform such studies, but it should always be remembered that these radiographs take time. So instead of a bedside or a portable radiograph, we can perform a contrast enhanced CT scan study at the same time. So abdominal x-rays can have some value in certain conditions, but it should not be at the expense of the patient. Then another very specific study that we perform is either a cystography or a urethrophy. In this, a contrast medium is introduced in the urogenital system in a retrograde fashion. That is, it is introduced against the flow of the urine. So via these studies, we can look at both the urethra, the urinary bladder, and even the ureters and the pelvis of the kidney. Now, like I said, that even radiographs have value when some contrast is injected. The gold standard for a urogenital exam is a contrast enhanced CT scan. Now, here is an example of a contrast enhanced CT scan. Now, for this, you can see that the right kidney is normal. We can see its cortex. It is isoechoic with all the other viscera. The collecting ducts are very visible in the both kidneys, and we can also appreciate the medulla. But on the left kidney, we can see that there is some laceration here. Now, this laceration can result in both parenchymal discontinuation, parenchymal injury, and can even result in hemorrhaging. So whenever we perform a contrast enhanced CT scan, first we use an arterial phase if there is some evidence of hemorrhage either on the physical exam or on the fast exam. Then we perform a delayed phase during the CT scan. The delayed phase examines the parenchyma of the viscera. So during this is the delayed phase, and the axial CT scan, where we can see that the cortex of the left kidney is discontinuous, is lacerated, and there is also evidence of hemorrhaging. Another study that we can perform in trauma is an angiogram. Now, for angiogram to be performed, one must have some evidence of bleeding, either the fast exam or some evidence on the arterial phase of the CT scan. So if we get confirmation that there is hemorrhage inside the patient, then we perform an angiogram. And during the angiogram, what we do is that we visualize the vasculature around and in the kidneys and find out where the bleed is coming from. Now, in this example, there is exavasation of renal artery. In order to stop it, we have performed catheterization and introduced coils inside the lumen, which have stopped the hemorrhaging. So angiograms have the benefit of being non-invasive, and then we can pinpoint the exact point of hemorrhage, and then we can stop it either in this example with coils or with embolization. Another study that we perform in trauma, like I mentioned before, is a retrograde cystogram. Now, here is an example of a retrograde cystogram. What we do is that we introduce a Foley's catheter, and with this Foley's catheter, we introduce a contrast medium. And when this contrast medium is introduced in the urinary bladder, it mixes with the urine and produces the opacified urine. So we can appreciate at this area that there is no rupture of the wall of the urinary bladder, and it's continuous, it's smooth, nothing is wrong here. But at this site, we can easily tell that there is extravasated urine, or the wall of the urinary bladder has ruptured. So, with a retrograde cystogram where the contrast medium is introduced via the Foley's catheter, we can easily rule out if there is some kind of rupture or leakage of urine after the trauma. Now, in this X-ray, do remember that there is this diastasis of pubic symphysis. Now, diastasis means widening because pubic symphysis is always joined together. Whenever there is widening or fracture, it's very important to keep that in mind. We'll discuss this in the next slides. Now, this is a CT scan. The previous one was a KUB contrast enhanced radiograph. This is an axial CT scan of the same patient. Here we can easily appreciate both the bladder with its posterior wall that is not ruptured, and the placement of Foley's catheter, and the anterior extravasation of the urine. Now, as I mentioned before, whenever there is a fracture or diastasis or pubic symphysis, there's always 100% chance that some kind of injury or insult has happened to the urethra of the patient. So we have to look at it. We have to perform the study to see if the urethra is intact, if it has ruptured, or if there's some minute leakage, or if there's some kind of hemorrhaging. Whatever the cause is, usually it is due to the diastasis or the fracture of pubic symphysis. Now, in this radiograph, the contrast medium is introduced via the catheter into the urethra. Now, this is the anterior urethra and this is the posterior urethra. Now, the posterior urethra has ruptured, rather it has obliterated because of the diastasis and fracture of the pubic symphysis. Now, you can not see the diastasis, but you can appreciate that both the ischium are not at the same level. So one can easily judge that there is some diastasis or fracture that has happened, which has led to the leakage of the contrast medium from the posterior urethra. So this is the point of the rupture, and all of this is the leakage of the contrast medium or the extravasated urine. Now, another topic where imaging is required is whenever we suspect there is some kind of renovascular hypertension. Now, in essential hypertension, where it is treated medically, no imaging is required. Medicines are given according to the patient, according to its comorbids, its age, everything. But if renal stenosis is suspected, that would lead to the suspicion of a renovascular hypertension. So in order to either confirm it or to rule it out, we perform certain modalities, certain studies to do this. Now, the first one of those is a CT angiogram or an MR, magnetic resonance angiogram. Now, both of these are important because CTA is performed in patients with advanced problem with some kind of advanced renal failure, and MRA is performed in patients with mild to moderate renal failure. Then we can always perform sonography, and if that ultrasound is coupled with a Doppler study, we can always find out if there is some kind of stenosis or the narrowing of the renal artery. So, in the Doppler ultrasound, we actually look at the velocity by which the blood is flowing through the renal artery. So, if it's high enough, we can confirm that it is actually hypertension of renal cause. Another study, that is really performed, is an ACE inhibitor renal scintigraphy. Now, in this study, what we do is that we introduced ACE inhibitors, or the angiotensin converting enzyme inhibitors. Now, angiotensin converting enzyme is found in the kidneys. So, in order for the angiotensin 1 to convert to angiotensin 2, this study provides a definitive functional aspect of the kidneys. So, if the ACE inhibitor test is going right, there is no hypertension of renal origin. If it is positive, then we might suspect that the hypertension is actually from the renal area. Now, if renal artery stenosis is suspected via either of these modalities, we can always confirm it with angiography. Now, with angiography, what we do is we introduce catheter inside the body, we introduce the contrast medium, and then we take rapid X-rays or CT scan studies. Now, with angiography, definitive answer or the confirmatory test can be done either to confirm or to rule out renal artery stenosis. Now, this is an example of a renal Doppler sonography. Now, what we do here is we actually look at the renal artery, and then we start to look at how the velocities of the blood before the narrowing and after the narrowing is affected. Now, if the velocity of the blood is more than 180 centimeters per second, and the ratio between the aortic velocity and the post-stenosis velocity is more than the ratio of 3.5, this confirms that renal artery stenosis is present. But as with all ultrasound study, this is usually dependent upon many factors. Because of its low resolution, it is usually dependent upon the expertise of the person that is performing the study. It can be dependent upon variety of the patient factors such as the obesity or the location of the stenosis of the renal artery. So this study, even though gives us suspicion and may confirm the diagnosis of renal artery stenosis, but it is not the gold standard for it. Another modality that we can use to either confirm or rule out renovascular hypertension is both CTA and MRA. That stand for CT arteriogram or the magnetic resonance arteriogram. Now, in MRA, we use gadolinium based contrast enhancement material, which is relatively safe for the kidneys as opposed to the iodine based contrast material that is used in CTA. So, for the patients with mild to moderate renal insufficiency, we perform MRA. But for the patients with advanced problem, we usually perform CTA. Now, gadolinium is used, especially if it's used frequently, multiple times, and if the patient is on dialysis, contrast medium is usually filtered out, both the iodine and the gadolinium based. So we can perform both the MRA or the CTA in such patients. But if patient is both in advanced stage and not on dialysis, there are certain other studies that we can also perform, such as we can perform unenhanced MRA with flow phase, where we observe the flow of the blood inside the vessels. But this is all done via a specific phase of the MRI. And another very uncommon study but still important is where we inject carbon dioxide inside the artery via catheter. Now this carbon dioxide flows with the blood and provides kind of a negative contrast enhancement on the images. So not only we can perform CTA and MRA in various situations, we can perform certain other studies too, such as this. This is a CTA with a maximal intensity projection. Now, what is a maximal intensity projection? You have to look up for my lecture on the introduction to radiology. Now, in this, we can easily appreciate the stenosis at the root of the aorta. Now, as I mentioned earlier, the site of stenosis is very important. Why it is important? Because the site explains the velocity and both the advancement of the hypertension and the renal artery stenosis. Now, in the next study, what we are doing is that we are inserting a catheter in the femoral vein, introducing the contrast medium, and then taking rapid images of those contrast media. Now, in this, we can easily appreciate that there is some kind of stenosis here, even with the catheter inserted. So the contrast media has moved into the kidney via the femoral artery, but not through the renal artery. Now, through both the MRA and the CTA, we can also judge how much stenosis has taken place. If it is less than 50%, it is considered mild. If it is between 50 to 70%, it is considered moderate. If it's more than 70%, it is considered severe and surgical intervention must be performed. Now, one of the common surgical interventions that can be performed is a balloon dilatation inside the artery. Now, this is an example of that same patient with the stenosis at the root of the aorta. But now both the balloon dilatation and stents have been placed. So the artery has again dilated and the usual blood flow has resumed. So the renal artery stenosis has been reduced. Our next topic is the acute onset of flank pain. Now, usually flank pains are either colicky or spasmodic in nature, and they are usually due to presence of calculi in the urinary system. Now, in order to appreciate where the calculus lie, we can perform a lot of modalities. We can perform ultrasound, we can perform CT scan, though usually ultrasound is the go-to modality in case of a renal colic, but it does not give us the exact location of the calculus. It does not give us the image of the calculus, and it is all dependent upon both the site, the impaction, and the calcium content of the said calculi. Now, if that calculi is lodged in the ureter, we cannot discern if it is impacted or not. Now, if there are certain conditions which prohibit us from using ionizing radiations which are used in CT scan, such as in pregnancy or in children, we go for ultrasound. But for the rest of the patient, the gold standard is to perform a CT scan. Now, this is a CT scan of a patient with a renal calculi. Now, you can easily appreciate the calculi near the posterior aspect of the bladder, and this calculi is rather large in size. Now you can also appreciate that along with the calculi, the ureter is also distended. This usually happens if the calculi has lodged in between the ureterocysto junction, that is the junction between the urinary bladder and the ureter. Now if the calculus is lodged there, then the distension of the ureter is usually observed, and that is the case that is happening here. Now this is an same CT scan but with more detail. It's a zoomed in picture of the same CT scan, and you can easily see that there's a small calculus here. The ureter is dilated, and there is some haziness due to soft tissue around the calculus. Now, why the presence of hazy soft tissue around the calculus is important? Because during the CT scan studies, we look out for not only the renal calculi, but we can also find some phlebolytes. Now, phlebolytes are calculi or concretions or stone inside the veins. Now, whenever we do an axial CT scan, they look exactly like a renal calculi, but they are not at the same place. Now, in order to differentiate both, what we can do is with the phlebolith, its margins are clear and they are spherical. They are not hazy, they're clear. But because of the soft tissue haziness around the renal calculi, because of the dilated ureter in which it has lodged, its appearance is different. Now, if a renal calculi is not present inside the pelvis of the kidney where it is formed, but instead has lodged inside the ureter and has not impacted, one of the most common procedures that can be performed to eliminate is the insertion of a DJ stent. Now, DJ stands for double jointed stents. Now, here you can appreciate that stent has been placed through the urethra into the urinary bladder, then the ureters, and then inside the pelvis. Now, because it is jointed, it locks into the place, displaces the calculi, and that displaced calculi then can be excreted out. Now, if the calculi is small, we do not have to perform such measures. We can even perform conservative measures such as infusion of fluids, intake of large amounts of water, which causes diuresis, and diuresis then in fact causes the dislodgement of the calculi. But if the calculi is large, impacted, catheterization, especially a DJ stent placement, is a must. So this is the obstructing calculi, and it has impacted inside the ureter, and the blood flow and the urine flow from the kidney is not working. It is not going inside the urinary bladder. So in order to give it an alternative path, an alternative route, we place a stent or a catheter inside it, which makes the flow of the urine easy into the ureter and into the urinary bladder and then outside. The next scenario that we're gonna tackle is acute scrotal pain and scrotal masses. Now, usually scrotal pain is either due to some kind of trauma or pain due to some kind of an inflammatory disease or due to presence of masses inside the testes. Now, for both the scrotal and testicular imaging, our modality of choice is ultrasound because it is both diagnostic, because we do not require high resolution imaging to diagnose scrotal and testicular problems, because on an ultrasound we can look for the presence of fluid, we can look for the blood flow, we can look for the extent of the injury, we can categorize the mass, and we can even find out, if we perform a Doppler study, if we have epididymitis, that is the inflammation of the epididymis, or a scrotal torsion, testicular torsion. Now, this is an ultrasound image of scrotum. Now, we can easily appreciate that there is presence of fluid inside the scrotum, and the testes have moved to the side of it because of the presence of the fluid. Now, the presence of fluid inside the scrotum is usually labeled as a hydrocele. It is a benign condition and can easily be dealt with via the aspiration of the fluid. Next problem that we usually encounter is trauma to testes and the scrotum. Whenever we find trauma, we usually look for either there is some kind of frank disruption of the surface of the testes, or there's some kind of discontinuation or the laceration in the parenchyma of the testes. If either of those are present, we can usually say that trauma has taken place to the testes, and if there is some kind of hematoma, it is present, it must be dealt with, it must be aspirated, and it must be taken as an emergency before ischemic changes start to take place inside the scrotum and the testes. Now, like I said, on a scrotal sonography, we can perform Doppler testing too. Now, with Doppler testing, we can find out if the patient is suffering from either epididymitis or testicular torsion. Because in epididymitis, there will be increased blood flow because of the inflammation of the epididymis towards the testes. But in testicular torsion, because of the torsion or the twisting of the testes, the blood flow will be reduced. Now, here is a comparison. This is an ultrasound of a patient with an epididymitis. You can easily find out that the blood flow has increased to this particular testes. So this patient is suffering from epididymitis, and whenever we look for Doppler study in one testes, we always look at the other one for comparison. So in order to compare it to the other one, we can easily see that blood flow here is normal, but in the previous one it was so much increased that it led to the suspicion and diagnosis of epididymitis. Next, we have the duplex sonography. Duplex sonography actually means that we perform both the ultrasound study and the Doppler study at the same time. Now, it is usually done when we have to find out both, when we have to look at the both the structure of the organ and the blood flow. Now, in testicular torsions, both the structure of the testes is changed, it is inverted, and the its blood flow towards it is reduced. So we can find out both of these in a duplex sonography. So you can easily appreciate that both testes are of same size, but the right one is normal, the right one has extremely reduced blood flow, and the left one has normal blood flow with normal arterial and venous blood flow. So we can easily deduce that the right testes might be undergoing testicular torsion. Usually, such diagnosis is made both on the ultrasound and on the physical examination. Another common problem that we can find in testes is a varicocele. Now, varicocele can be defined as a accumulation of dilated tortuous veins inside the testes. So, on Doppler, if we find out a collection of tubular structures which are clumped together, we can easily make the diagnosis of a varicocele in the testes. So, you can easily appreciate that instead of small blood flow pattern, we have large tubular structures of both the arterial and venous origin. So such kind of tortuous clumping of blood vessels in the testes is termed as a varicocele. The next scenario that we are going to tackle is scrotal masses. Now, scrotal masses are of usually two types. They're either extratesticular or they're intratesticular. Now, extratesticular masses are usually considered benign and intra are usually considered malignant. Now, here we have an example of a spermatocele. A spermatocele is a benign pouching from the epididymis of a testis inside the scrotum. It is benign, does not result in any malignant condition, and does not require any specific treatment unless it causes any symptoms or reduced fertility, such as infertility or subfertility. Next, we're going to study about the intratesticular masses. One of the most common intratesticular mass is a seminoma, which is usually derived from the lining of a testis. Now, this is an ultrasound image of the seminoma. Now, here you can easily appreciate that this mass is hypoechoic to the normal testicular mass, and this mass inside the testes is a seminoma, that it is derived from the walls of the testes and it is of a malignant nature, as opposed to the extratesticular masses such as spermatocele, which is also known as an epididymal cyst. So, such malignant problems should always be evaluated, should always be staged, and treatment should be started immediately so as to reduce any kind of metastatic activity and to give the patient palliative care and to further evaluate the condition and the histopathology of the said cancer. Next, we're going to study about microlithiasis inside testes. Now, usually what happens is that testes do not contain one single large calculus, but it is usually aggregates of small gravel or microlithiases inside the parenchyma of the testes. Now you can easily see that they are multiple, and a lot of them are developing, they're increasing in size, and they are of particular importance because microlithiasis inside a testis is always of premalignant stage. So it might lead to a seminoma, it might lead to some kind of a urothelial derived malignant disease such as a transitional cell carcinoma. Whatever it is, microlithiasis always results in a malignant disease. So if a patient suffers from such, he should be informed, and further studies must be conducted out to see if any or all cancers or malignant diseases are taking place. So this was the part 1 of the lecture on uroradiology, in which we studied about the male and female urinary system and the male genital system. We will study about the female genital system in a separate lecture. So what did we study in this lecture? First, we studied about the trauma to the urogenital system, which modalities to use to confirm it, to diagnose it. Either we use radiographs, either we use CT scans. If we use CT scans, then we use contrast enhanced CT scans. If we use magnetic resonance imaging, we study all of those, which modalities are used in which condition and which conditions do not require any imaging. Then we studied about renovascular hypertension, that how it is different from an essential hypertension that is treated medically. What is the cause of a renovascular hypertension, how it can be diagnosed via imaging, what is the difference between CTA and an MRA, what is the use of the ultrasound in such diagnosis. We also learned about certain uncommon imaging techniques such as the ACE inhibitor scintigraphy or the CO2 studies inside the renal artery. Then we studied about the acute pain in the flank region. We learned that it is usually caused by renal colic. Then we learned about what is the cause of the renal colic, how it is presented to the patient, what different calculi might be present, where they might be present, what constitutes an impacted calculi, and how it can be treated conservatively or it can be treated via a stent. Then we learned about the scrotal masses and acute scrotal pain, that what are the causes of the scrotal pain. Is it trauma? Is it some kind of inflammatory disease, or some kind of benign process is happening, such as an hydrocele or a varicocele or testicular torsion or epididymitis? All of these result in acute testicular pain. Then we learned about the scrotal masses. We learned about the extratesticular and the intratesticular masses, which are benign and which are malignant. Then we learned about the microlithiasis and why microlithiasis can be termed as a pre-malignant state. So we learned about all of this in this lecture. So thank you so much for watching sqadia.com.